A synoptic pathology report for gastrointestinal stromal tumor. Welcome to our deep dive into the pathology of gastrointestinal stromal tumors. Today, we present a synoptic pathology report, thoughtfully adapted for a podcast audience, following the rigorous standards of cancer reporting. Patient background. Our case involves a patient who underwent a laparoscopic partial gastrectomy, specifically a wedge resection. The specimen received for analysis was a portion of the stomach, removed from the gastric body along the greater curvature. Macroscopic findings on gross examination. The tumor measured 4.2 centimeters at its largest dimension. It appeared as a single, well-defined nodule displaying a solid, tan white, whorled-cut surface, accompanied by some areas of hemorrhage. Notably, there was no evidence of extensive necrosis or cystic change. The tumor was completely surrounded by normal gastric tissue, with the closest surgical margin at 1 centimeter from the tumor edge. The mitotic rate was recorded as 4 mitoses per 5 square millimeters, counted in the region of highest activity. Focal necrosis was present, involving less than 5% of the tumor area, and there was mucosal ulceration. No lymph nodes were identified in the specimen. Microscopic findings under the microscope. The diagnosis was confirmed as a gastrointestinal stromal tumor. The predominant cell type was spindle cell, accounting for more than 95%, with only a minor epithelioid component. The tissue was moderately cellular, and cytologic atypia was mild to moderate. The tumor demonstrated expansal, pushing borders, without clear evidence of invasion into the muscularis propria. Importantly, all surgical margins, both deep and circumferential, were free of tumor. There was no sign of lymphovascular or perineural invasion. The background gastric mucosa showed chronic gastritis, but there was no intestinal metaplasia, dysplasia, or presence of Helicobacter pylori. Ancillary studies. Immunohistochemistry results were crucial in confirming the diagnosis. The tumor cell showed strong and diffuse positivity for c-KIT, also known as CD117, and DOG1. Both markers that are central to identifying gastrointestinal stromal tumors. The cells were also positive for CD34 and demonstrated focal positivity for smooth muscle actin. Markers such as S100 protein and desmin were negative, helping to exclude other types of mesenchymal tumors. The tumor retained expression of succinate dehydrogenase subunit B on the molecular level. A mutation was detected in exon 11 of the KIT gene, specifically a change from thymine to adenine at position 1676, resulting in a valine to aspartic acid amino acid substitution. No mutations were found in the platelet-derived growth factor receptor alpha gene. Risk assessment. Risk stratification followed the modified National Institutes of Health consensus criteria and the Armed Forces Institute of Pathology guidelines. The tumor was located in the stomach, measured 4.2 centimeters, and had a mitotic rate of 4 per 5 square millimeters. These factors placed the tumor in the moderate risk category for aggressive behavior and recurrence. Pathologic staging. Using the 8th edition of the American Joint Committee on Cancer Staging System, the tumor could not be fully staged due to limitations in assessing the primary tumor and lymph nodes in this context. It is important to note that for gastrointestinal stromal tumors, the traditional tumor, node, and metastasis staging system is not considered the primary prognostic tool. Final diagnosis. In summary, the specimen was a wedge resection of the stomach, revealing a gastrointestinal stromal tumor of spindle cell type, measuring 4.2 centimeters, with a mitotic rate of 4 per 5 square millimeters. Focal necrosis and mucosal ulceration were observed. All surgical margins were negative, and there was no evidence of lymphovascular or perineural invasion. The immunophenotype was positive for CD117, DOG1, and CD34, supporting the diagnosis. Based on the tumor's location, size, and mitotic rate, it is classified as moderate risk. Commentary. The combined morphological and immunohistochemical features, including strong positivity for CD117 and DOG1, confirm the diagnosis of gastrointestinal stromal tumor. Risk assessment incorporates the site, size, and mitotic activity, leading to a moderate risk categorization for disease progression or recurrence. The presence of a KIT exon 11 mutation is the most common genetic finding in gastrointestinal stromal tumor and suggests a favorable response to targeted therapy with imatinib mesylate, should additional treatment be indicated. As always, correlation with clinical and imaging findings is recommended for comprehensive patient management. Summary of key elements. This report utilizes a structured, checklist-based format to capture all essential prognostic information. The most critical factors influencing prognosis are the tumor's location, size, and mitotic rate, which guide risk stratification and subsequent clinical management. Diagnostic immunohistochemistry with CD117 and DOG1 is fundamental, while molecular analysis of the KIT gene supports therapeutic decision-making. Achieving clear surgical margins is a vital goal, and the results are clearly communicated for the benefit of the clinical team. This comprehensive template can be adapted for gastrointestinal stromal tumors arising in other gastrointestinal tract locations, with risk assessment tailored according to site-specific criteria. Thank you for joining us on this episode. If you found this content insightful, please like, share, and subscribe to our channel. You've been listening to the Everything Surgery podcast, dissecting the extraordinary.